When discussing diabetic ketoacidosis, you want to know the important definitions. You want to know those facts that are pertinent to the pathophysiology of diabetes mellitus, and you want to know what diabetes mellitus is, and henceforth it is important to actually have an idea of what the types of diabetes mellitus are, because then you know which patients potentially have diabetes, and those are the types of patients that you will be able to address and think about the moment you are thinking about DKA, which means when you have that idea plus the clinically relevant pathophysiologic concepts related to DKA and how it happens, then you can recognize the symptoms. And when you're able to formulate a recognition at the time of referral and at the time of examining the patient, then you'll be able to know that this is a potential diagnosis and be able to treat quickly. Which means you want to know how to diagnose promptly, and you want to know the differential diagnosis, and you want to know the principles of treatment. That is, when you know the principles behind treating DKA, you will never get it wrong, and you shouldn't, because that would be dangerous. So, what is diabetes? Diabetes mellitus is a chronic metabolic disease characterized by elevated plasma glucose levels because of insulin deficiency, impaired action of insulin secondary to insulin resistance, or a combination of both. No matter what the mechanism is, that postulates diabetes mellitus. Now, the diabetes is formally diagnosed along with prediabetes based on elevated plasma glucose levels below or above certain diagnostic criteria and below or above the normal ranges, respectively. So that is something that you can refer to. But for the sake of our discussion, I'm going to move on and forge ahead with the types of diabetes. Why? Because when you know that there are many types, then you also know that there are many groups of patients that can have diabetes, and potentially, hypothetically speaking, any one of them can develop DKA, but the ones that really have the most minimal action of insulin are the ones that are at risk when there is no insulin function at the time of presentation. And for how long before that, of course. Type 1 diabetes, you can see that over here is the diabetes that is recognized most commonly by scientific communities as the autoimmune one, and type 2 is the one where there is resistance to insulin. Now, the recognition of type 1 is no insulin, type 2 is insulin resistance. 1, no action, type 2, there's a lot of insulin, but there's no action because it does not work. That is important because the type 1s will probably have lower resistance to insulin, whereas the type 2 are going to have higher resistance. So that will also make a difference on your dosing when you're treating the patient. You see how having that in mind is also important? Gestational diabetes is a diabetes that occurs in pregnancy, at the time of pregnancy. And diabetes LADA, so LADA is the abbreviation for latent autoimmune diabetes of adulthood, and it is a form that is relevant or related to type 1 diabetes, but instead of developing slightly earlier in age, it would develop slightly later. And then you have diabetes MODY, MODY, which is maturity onset of diabetes in the young. And this is a type of diabetes that is more likely to be one that comes with inheritance amongst the other types, and it is comparable to type 2, so there is insulin resistance component, and it comes in the younger. Then there's double diabetes, which inherits both mechanisms in it. Type 3 diabetes is more of a scientific and a historic entity where there's a relationship between type 1, 2, and Alzheimer's disease. Really not relevant for our discussion except for completion's sake. Steroids increase, one of the functions of steroids, they increase insulin resistance in the body. So you can have a steroid-induced diabetes and steroid-induced diabetic ketoacidosis. Brittle diabetes, that's the one that will be brittle. So it's going to have, it's going to describe the particularly hard to control form of diabetes, usually type 1, that takes insulin most of the time because you're going to have fluctuations between high glucose hyperglycemia and low glucose hypoglycemia, a lot of those patients are going to require an insulin pen and a glucagon pen so that they can quickly revert and treat an attack of hypoglycemia, which also happens to be a medical emergency. Secondary diabetes is a form of diabetes that is a consequence of another medical condition, and it could be anyone. Of note, hemochromatosis, a deposition that destroys your pancreatic cells, or cystic fibrosis, chronic pancreatitis, because also the inflammation will destroy. So any inflammatory or deposition or invasion of your pancreatic cells can also cause that, and or any other autoimmune disease that or endocrine disease or condition or medication that increases your insulin resistance. Those would be, if I can think off the top of my head, those would be things like Cushing's disease, for example. And pancreatectomy, of course, is a condition. Steroid, as we mentioned, is a medication. And finally, there's a descriptive term, and it's nothing more than a descriptive term, really, that is juvenile diabetes. Juvenile diabetes just simply describes the diabetes that occurs in the young. So it could be type 1 diabetes for all purposes. Which types of diabetes are pertinent to diabetic ketoacidosis? Type 1 is probably the most important. What is gluconeogenesis? Notice how we're discussing a medical emergency, but we're really anchoring at some fundamental, basic pathophysiologic concept. So gluconeogenesis is a physiologic concept, and it is the metabolic pathway that results in the generation of glucose from certain non-carbohydrate carbon substrates. This happens when your body starves. So what if your body isn't actually starving but is incapable of recognizing nutrients because it can't process them, because the key way, the key to entering the cell is insulin, so insulin doesn't exist or doesn't work. So the body is in a pathologic state in which the pathophysiology gives it the signal of starvation even when it is not. And so gluconeogenesis kicks in, and you're trying to formulate, to generate glucose from non-carbohydrate carbon substrates, and that increases the byproducts of this formula, or the byproduct of this function, the gluconeogenesis, into the blood, and that creates some added substances that can add to the osmolality of the blood. Please keep that in mind, because our blood's osmolality usually comes from the major electrolytes and major proteins. And so sodium, chloride, potassium, bicarbonate are actually the major contributors to our osmolality. What is the difference between ketoacidosis and diabetic ketoacidosis? So obviously, from a linguistic point of view, it just automatically means that diabetic ketoacidosis is simply one form of ketoacidosis. So the differential diagnosis of diabetic ketoacidosis would be the other causes of ketoacidosis. So a gastroenteritis, a hyperosmolar hyperglycemic state, a myocardial infarction, a pancreatitis, and starvation. See, in all those cases, there is potential for starvation, either because there is, for example, here, you cannot pump blood back and forth, so you cannot deliver nutrients. Here, you cannot process some of your digestant material, and you cannot process some of the energy, whether because you cannot release insulin because the endocrine aspect of the pancreas is destroyed, or even because at a long term, if you cannot process the types of foods that you're eating, then you can also have the starvation effect. Or actually, you're starving. There's no food coming in. And then you want to know that high anion gap metabolic acidosis, those conditions, all of them can lead to ketoacidosis. Alcoholic ketoacidosis, ethylene glycol intoxication, which will cause ethylene glycol ketoacidosis. Lactic acidosis will give the picture of ketoacidosis. Ethylene glycol intoxication will also add substrates in the body that will cause acidosis with an added anion. So ketones are anions, and ethylene glycol can add byproducts that are anions. The lactic acid can add anions. Methanol intoxication, same idea. Paraldehyde ingestion, rhabdomyolysis, salicylate intoxication, and uremia. What other important ketoacidosis should you know about? Just to reiterate that alcoholic diabetic ketoacidosis and hyperglycemic hyperosmolar state can also have a ketoacidotic content because they can have low to normal ketones. So, what other important ketoacidosis should you know about? That would be alcoholic ketoacidosis. The following are very important emergencies. So alcoholic ketoacidosis and diabetic ketoacidosis, and a non-ketotic state, but also related to diabetes, the hyperglycemic hyperosmolar state. And the reason we can discuss that is because diabetes mellitus and non-ketotic hyperosmolar conditions, that would be the components of hyperosmolar hypoglycemic state, which can lead to coma if not treated promptly, and can have a myriad of metabolic effects, and it can be precipitated and or cause other organ dysfunction. So an MI and decreased perfusion to the body tissue in an elderly person, for example, with long-standing diabetes type 2, who happens to have high insulin resistance, that can precipitate hyperglycemic hyperosmolar state. And hyperglycemic hyperosmolar state in its turn is also going to increase the osmolality, the viscosity of the blood, the state of dehydration, and the lack of processing of nutrients, and exacerbate the myocardial infarction further. And you can apply similar concepts to other organ systems. So that's for hyperglycemia. For ketosis, whether starvation or alcoholic or diabetic ketoacidosis, and you have the metabolic acidosis, which happens in multiple other states, whether it is a normal anion gap or a high anion gap metabolic acidosis. The normal anion gap hyperchloremic acidosis is a specific condition that can come from diarrhea, renal tubular acidosis, rapid large volume saline infusion, and the high anion gap metabolic acidosis will come from the lactic acids, whether the L or D lactate, salicylates, ethylene glycol, methanol, polyethylene, renal failure, meaning uremia, and drug induced, like we mentioned before. And you may want to look up the mnemonic mud piles. Now, how does diabetic ketoacidosis happen and why? So if your insulin helps your skeletal muscle increases glycogenesis and increase protein synthesis, at the same time it helps the liver increase glycogenesis and decrease gluconeogenesis. And so basically insulin helps the uptake and the build-up process, right? And that is the anabolic process. And so you have adipose tissue will also increase adipogenesis and decrease lipolysis. So when insulin decreases, your body goes in a breakdown state. That's catabolism, right? So gluconeogenesis, glycogenolysis, protein catabolism, which is also a form of gluconeogenesis, and lipolysis. And from lipolysis, you can have ketone bodies, and that will increase your added anion to the blood, which increases your anion gap, and we call it a gap because you cannot measure for those anions in your normal lab investigations. You have to order a specific ketone body assessment in blood or in urine. How does DKA happen? So the concept is to understand that despite blood sugar accumulating outside the cells, they cannot go in. So it's like as if the cells are seeing a really delicious glucose meal on the outside, but they cannot absorb it in, and that makes them angry. And so hence the cells starve and resort to gluconeogenesis because they want to survive. And subsequently, excess ketones from lipolysis will be exported into the blood, and so the transcellular shift occurs. A lot of shifts will actually occur here because you want to compensate and try to maintain the body osmolality, but what happens is now you have an anion gap because you have a higher content of an anion that shouldn't be in the blood to begin with. And so when you measure your potassium, calcium, sodium, and bicarbonate contents and subtract the positives from the negatives, you're going to get an absolute value that is higher than the expectant number. We're going to come to that in a bit. And so if you look at this chart, you know that absolute insulin deficiency can increase immediately lipolysis and fatty acid destruction and ketogenesis, and will deplete your alkali reserve as your body tries to buffer through. And when that gets depleted, then your measured pH will be high. And by that time, the ketone bodies are far too many. And that will mean that you're going to have a state of diabetic ketoacidosis and a potential state of hyperlipidemia. When you have some counter-regulatory hormone or relative insulin deficiency, so some insulin is still there, or but it's either not working or it's partially deficient, then you will also have some glycogenolysis happening to try to release glucose from glycogen stores itself, and that will also cause you to have hyperglycemia, which will be contributed to by absolute and counter-regulatory and relative insulin deficiency, leading to DKA. But as you have more and more insulin function and a prolonged state of this decrease meet in demand or a stress state combined with dehydration due to the loss of water and glycosuria, then a hyperosmolar state can also be combined with DKA or can be its own independent emergency. The reason I liked to kind of show you this and stress on this this point individually is because a lot of times the elderly person who has had a long-standing type 2 diabetes with massive resistance, the pancreas gets really tired over time. So it actually starts to become under-functioning. And what that means is you're not only going to have high insulin resistance, you're also going to have relative insulin deficiency because the pancreas isn't working anymore. And so you can have a hyperosmolar and DKA conditions at the same time. So the osmolality will be off the charts, the blood glucose will be off the charts, and the body will be acidotic. And if you measure the anion gap, it'll also be high. Diagnose that by adding ketone bodies. It's high, and there you go. You have both conditions. The pathophysiology in a nutshell: DKA is caused by uncontrolled lipolysis, not proteolysis, which results in an excess of free fatty acids that are ultimately converted to ketone bodies.